Good afternoon, everybody. This is John, and to let you know, I'm a veteran of the United States Navy. Every day, our society's young men and women decide to support and defend our country. Our government takes them, trains them, and sends them out to fight for us. Many of them come home perfectly fine, but others have physical disabilities, psychological disabilities, and too many of them just pay the ultimate price. This presentation is developed to provide you some insight to the psychological health issues facing our service members with a focus on post-traumatic stress disorder. Since this presentation can only be about 15 minutes, I'm not going to have the luxury to get into a lot of detail, but I will provide you with a brief overview of PTSD, coping skills, understanding how to work with a service member or veteran, reintegration, crisis management, and we're going to wrap it up, with a brief summary. So let's get right into it. According to the American Psychiatric Association, PTSD is a psychiatric disorder that can occur in people who have experienced or witnessed a traumatic event such as natural disaster, a serious accident, a terrorist act, war, combat, rape, or other violent personal assault. This is a very real condition that has both physical and psychological effects. PTSD is a signature injury and most frequently diagnosed condition for veterans of Iraq and Afghanistan conflicts. 2.5 million people were deployed during these two conflicts. 20% of them returned home with major psychological issues. So what are the effects of PTSD? Well, physically, deep within the brain lies a set of neurons called the amygdala, and that controls and regulates our emotions such as fear, stress, and anxiety. People with PTSD have an amygdala that is smaller in volume than those without PTSD. Psychologically, depression, anxiety, sleeplessness, and mood swings are common symptoms. And this can lead to additional problems such as drug and alcohol abuse, which further compound the problem. PTSD not only affects individuals, but their problems generally transfer to the family, which causes other issues with quality of family life, parenting, and other interpersonal relationships. If it's left untreated, this often does lead to suicide. Of the 500,000 returning veterans from Iraq and Afghanistan, only 150,000 of them seek professional help. Why is this? Logistically, quality care is geographically specific. Most VA centers are in military urban areas where there's a vast majority of vets who are unable to access the center. If they choose private treatment, the financial costs can be insurmountable. For those who can get into the VA center, 75% of them do not receive initial care for at least 3 years. The military culture also brings about barriers similar to peer pressure. After every deployment, service members are required to complete a post-deployment health assessment, or PDHA. More often than not, these unit leaders use various coercion techniques to entice service members to falsify this assessment. Independent studies found that the rates of service members having suicidal thoughts are somewhere between 2 and 4 times higher than what's reported on the PDHA. Finally, the social stigma of having a mental illness is one of the largest contributors, keeping a vet from seeking help. Many people in our society look down on veterans with psychological problems. They perceive them as weak and pity them, or simply do not believe PTSD is a real illness. So what can we do? Early detection is a key component to overcoming this condition very quickly. Currently, PDHAs are given post-deployment. Our military should actually baseline the service member's psychological health pre-deployment, and then monthly thereafter throughout the whole post-deployment process. Education is another major consideration. We must educate the service member, their families, and their leaders about PTSD and other mental illnesses. Bringing PTSD and suicide awareness to the attention of the public is going to help reduce the attached social stigma. Other options include, researching more effective treatments, expanding the care from individual treatment to family treatment, and create legislation to reduce the amount of time that our vets must wait to get into a qualified VA center. Coping with PTSD. First and foremost, veterans must recognize and accept the fact that they have PTSD and need professional help. Once they have accepted this fact, there are a number of available treatment options, including individual and group counseling, and a relatively new therapy, cognitive processing therapy. This is a specific type of behavior modification. Studies have shown that 53% of patients who undergo and complete this treatment no longer meet the minimum requirement for a PTSD diagnosis. In fact, 10 years post-treatment, the effectiveness is somewhere in the 80 percentile range. PTSD is the most common mental illness due to combat, but there's also a whole host of other mental disorders, such as traumatic brain injury, obsessive compulsive disorder, and depression and anxiety, just to name a few. The family of psychologically ill patients should really become familiar with multiple disorders, because more often than not, there will be more than a single diagnosis. Families should seek out couple-based treatment to address challenges with things like intimacy, communication, and parenting. Social support outside of the family will reduce PTSD symptoms by providing a sense of belongingness to the community. Our society needs to encourage family members to receive help as well, because the family must be healthy and available when the veteran is ready to accept help. Suicide prevention is slowly becoming a focus in the military. In fact, the U.S. Army was the first to implement a suicide prevention program focusing on developing life coping skills, encouraging help-seeking behaviors, raising awareness, and conducting suicide surveillance and analysis. One very important idea to remember is that suicide is not because someone wants to hurt themselves, but instead just wants the emotional and physical pain to stop. A family's understanding, persistence, and patience is needed to help the veteran. Persistence in that the family should never give up on each other. It is going to take quite a bit of time for someone to come to understand that they do need the help. This is where patience comes in. Never be pushy or nag. That's going to lead into a deeper withdrawal. We must build a foundation of trust and understand that only the vet can decide when they're ready for help. We need to know when to talk and when to listen. Sometimes they just want someone to listen without offering any advice. Finally, never, ever say that you can understand what they're going through. This is going to diminish any trust that was built. Most of us cannot fathom what these people have experienced. How can we possibly understand without experiencing it ourselves? Our community needs to be just as involved. Therapy plans need to be specifically designed for military personnel. Civilian trauma is completely different from military trauma. The results, they're identical, but the root causes are much different. As a civilian, you may think you could have done something more to protect yourself. But a military person was ordered into combat, and they carry a huge amount of guilt and shame for acts that they committed during these deployments. All psychological health care professionals should be trained in two distinct areas: military culture and evidence-based treatments. Civilian healthcare professionals who use evidence-based treatments do not usually understand the military culture. The few that do may not be trained to use evidence-based therapies for PTSD. So what can we do about that? Again, education and training is absolutely necessary to be effective. Educate the vets to self-identify, to learn the early warning signs of PTSD, and seek treatment. Educate the civilian providers on how to monitor for early warning signs of therapy dropout. and educate the family regarding effective communication techniques. We need to find more effective ways to disseminate information to the veterans regarding things such as available resources and services. We could expand telemental health services so that people do not need to travel outside of their comfort zone. We could also increase referrals to veteran community support programs such as Wounded Warriors or Veterans 3-Gun. Most veterans do not seek help for reintegration issues, even though there can be a significant amount of stress. Problems around finances and family have a huge impact on the rate of suicide ideation, to the tune of 5.5 times more even without a PTSD diagnosis, depression, or any other substance abuse factors. Many ex-service members have problems figuring out what their role is regarding the family. They've been away for so long, the spouse at home has had the responsibility to ensure everything has been provided for. So where does a veteran fit into this equation? What role should they assume in the family? Because deployments can range in length of time, some people need to really get to know their spouses again. Things change, people change. The person who left for deployment is not going to be the same one that returns. 40% of Iraq and Afghanistan vets report difficulties with reintegration. These folks spend a lot of time together during deployments, and maintaining that personal relationship after deployment or active duty can be very challenging. Many veterans have been in the military so long that they begin to feel like they don't belong in the civilian world and have a hard time finding a purpose for life outside of the military. Our last topic is crisis management. Guilt is the number one reason veterans commit suicide. Guilt is a very powerful emotion that contributes to terror and nightmares as a subconscious punishment to the actions taken while in a combat situation. In the military, personnel must always ask for permission to do just about anything. Therapists who understand the military way of life need to grant permission up front to the patient to allow them to forgive themselves of those actions. Overcoming that guilt is a cornerstone to any treatment plan. For veterans or family members who seem to be lost, telephone-based counseling systems provide an excellent method to receive help. Coaching into Care is one of those services that provide basic counseling. They provide information regarding symptoms of mental illness, techniques for effective communication, and help navigating the cumbersome VA healthcare system. Lastly, and most importantly, is the National Suicide Prevention Hotline. These individuals are available 24 hours a day, 7 days a week. There's actually a special extension specifically for veterans to obtain free support during a crisis, to get additional resource information and referrals, and a rescue service as well if it's actually needed. If you know someone in a crisis situation, the Lifeline can make all the difference. Well, it looks like I'm just about out of time, so we covered quite a bit here. We learned that PTSD is a physical issue as well as a psychological issue. We learned that the family is most important when coping with PTSD or any mental illness. We understand that a victim of PTSD needs to be the one to seek and accept help. Family and society cannot do it for them. We found that reintegration can be much more difficult than expected due to personal and family-related challenges. And finally, we have a better understanding of suicide prevention and managing of it through a crisis situation. In the time it has taken to view this presentation, there's a very good chance that at least one veteran just committed suicide. We must end this cycle. Losing 22 a day is unacceptable. Losing 16 a week is just too many. Losing 5 a month is too many. Losing just 1 is too many.